Acute cholangitis. This is one of those conditions you absolutely positively have to have locked down. A patient can walk in with some pretty vague symptoms and then become critically ill in just a matter of hours. So in this explainer, we're going to build a mental model for this disease. We'll walk through the entire clinical journey, right from the moment the patient presents to their definitive management. Let's dive in.
All right, we've broken this down into 6 key steps. First up, we'll get to the heart of what's actually going on. Then, we'll learn to spot the classic signs. After that, we'll map out the diagnostic pathway, figure out how to grade severity, talk about the crucial intervention of drainage, and finally, make sure we know how to stop it from ever coming back. So, what is actually happening inside our patient? Let's set the scene. At its core, this whole thing is really a story about bad plumbing and a nasty infection. Okay, so acute cholangitis, which you'll sometimes hear called ascending cholangitis, isn't just a simple infection. It's a full-blown syndrome that needs 2 key things to happen. First, the flow of bile gets blocked up. That's the stasis part. And second, that stagnant, backed-up bile gets infected. Usually it's bacteria climbing up from the gut. No blockage, no cholangitis.
So what's causing that clog in the first place? Well, by far the number one culprit you are going to see is a gallstone that's gone rogue and gotten stuck in the bile duct. Of course, you also have to keep things like malignancy or a benign stricture on your radar. They're significant players too. But just remember, that obstruction is the first domino that absolutely has to fall.
Now that we know what it is, let's focus on who we're looking for. What does a patient with acute cholangitis actually look like when they show up in your ER? Anyone who's been through med school has had Charcot's triad drilled into their head: fever, abdominal pain, and jaundice. It is the classic textbook presentation. But, and this is a huge but, look at that note at the bottom. It's only there in about half to maybe 3/4 of patients. So what does that mean? You can't hang your hat on it. If it's not there, that does not rule out cholangitis.
And if things get even worse, that triad can progress to what's called Reynolds pentad. This is where you add 2 really ominous signs: hypotension, so low blood pressure, and altered mental status, or confusion. When you see these, you are dealing with a much sicker patient. This is severe cholangitis with sepsis, and believe me, the clock is ticking a whole lot faster.
And who are the bad guys causing the infection? Well, it's no surprise. They're the usual suspects from the gut. E. coli is leading the pack with Klebsiella and Enterococcus right behind. And this is exactly why our first-line antibiotic choices need to cover these kinds of gram-negative and gram-positive organisms.
Okay, so our clinical suspicion is high. The story fits, the patient looks sick. How do we go from "I think this is what's going on" to "I know this is what's going on"? What's our investigative game plan? Right, this is the key question we've got to answer. And it's really a 2-pronged attack. We're going to need labs, and, just as important, we're going to need some pictures. We need imaging. So on the lab side of things, we're hunting for evidence of 2 things: infection and that biliary backup, cholestasis. You'll expect to see that white blood cell count go up. And crucially, the liver tests are going to show what we call a cholestatic pattern. That means you'll see a spike in the alkaline phosphatase, the GGT, and the bilirubin. And hey, don't forget to grab those blood cultures so you can target your antibiotics better later on. Now for the pictures. The order you do these in really matters. We always kick things off with a simple transabdominal ultrasound right at the bedside. It's fast, it's safe, and it's fantastic for spotting a dilated bile duct. If that's not giving you a clear answer, a CT scan can be a great next step to rule out other problems in the abdomen. But if you want that beautiful, definitive, non-invasive map of the biliary tree, MRCP is your gold standard. Yeah, this table really breaks down why we had that step-by-step approach. Ultrasound is your quick look, great for seeing dilation, but it really depends on who's holding the probe. CT is awesome for seeing that dilation, but it's actually pretty bad at finding the stones themselves. And while MRCP gives us the absolute best pictures, it costs more and isn't available everywhere 24/7. Each test has its own special job to do.
All right, let's get to a really critical decision point. As soon as you've made the diagnosis, you have to immediately ask yourself, how sick is this patient? Because the answer to that question is going to dictate how fast we need to move with everything else.
The Tokyo guidelines give us a really practical way to sort patients into 3 grades. Let's start with the absolute sickest, grade 3, severe. This one's easy. It's any patient who's showing signs of organ dysfunction. We're talking hypotension, confusion, kidney failure, you name it. Now, grade 2, or moderate, means they don't have organ failure, but they do have at least 2 signs of pretty serious inflammation, like a super high fever or a wacky white count. And grade 1, mild? Well, that's everybody else. They've got cholangitis, but they don't meet any of the criteria for moderate or severe.
Now, here's the thing. It doesn't matter if they're grade 1, 2, or 3. Every single patient with cholangitis gets admitted and started on these initial steps: IV fluids, fixing electrolytes, starting broad-spectrum antibiotics, and controlling their pain. These are the non-negotiable first-hour moves while we get ready for the main event.
Supportive care is absolutely vital, but it doesn't fix the root problem. The true cornerstone of treating acute cholangitis is getting that biliary obstruction unplugged. So the question is, how do we do it?
And this is exactly where all that work we did grading the severity pays off. For that patient with severe grade 3 cholangitis, drainage is a true emergency. It needs to happen ideally in less than 24 hours. For our mild to moderate cases, we have a little more breathing room, but we still need to get it done within 24 to 48 hours.
The undisputed champion, the go-to procedure, the gold standard for biliary drainage is ERCP. What's so amazing about this procedure is that it lets us do two things at once. We can see exactly where the blockage is, and we can fix it, all in one sitting. It's both diagnostic and therapeutic.
And if you're wondering why ERCP is the standard, just look at these numbers. This is the difference between life and death. In the old days, open surgery for this had a mortality rate that could be as high as 50%. We've gone from that to a procedure that's usually under 10%. That's not just an improvement, it's a revolution in how we treat this disease.
So, the drain is in, the infection is getting better, and our patient is starting to feel human again. We're almost at the finish line, but there is one last absolutely crucial step: making sure this never, ever happens again.
So let's ask the question. We've done the ERCP, we've relieved the blockage. Is the patient cured? The answer to that is a hard, unequivocal no, not even close.
Look, biliary drainage is a life-saving move, but it's a temporary fix. It's putting out the fire. To prevent it from starting again, you have to deal with what caused it. If it was gallstones, that gallbladder has to come out. If it was a stricture, it needs to be fixed. And if it was a malignancy, that needs to be addressed with stenting or surgery. You have to treat the root cause.
So if you only take one single thing away from all of this, let it be this right here. The next time you see a patient with a fever and jaundice, the very first question that should flash into your brain is this: is the biliary tract obstructed? That single question is the key that unlocks the entire diagnostic and management pathway for acute cholangitis.